So, hi, good evening, everyone. Thank you so much for taking the time out of your days to come and listen to my talk. I want to make sure that it's worth your time. So, thank you for the introduction. Just to kind of give you my own background on where I came from. So, I'm from the Detroit area, and somehow in medical school, I always thought that I wanted to be an eye doctor, and ophthalmology was going to be my career. So then I ended up meeting a few neuro-ophthalmologists, and I spent my year in fellowship doing clinical neuro-ophthalmology. During that year, I saw a few MS patients who had optic neuritis, and so it was interesting, but I was still set on ophthalmology. And then somehow I got to meet Dr. Elliot Froman, and so he's a very known neurologist and MS specialist in Dallas, Texas. And so then after that year, I spent a year with him down in Dallas as a research tech. And then I got to see all the different MS patients that he has, and I got to work with them, and I loved it. I thought it was the most amazing thing to develop such a long relationship with patients and to help them out, and they are actually motivated to help themselves out, and they want to participate in my research, and so it was great. So I decided, you know what, I'm switching careers. We're doing neurology, and then I want to be an MS physician. So after I did my neurology residency, then I went to the Cleveland Clinic in Ohio, and I did my MS fellowship there. And then I decided, you know what, I want to go and chase the sun. So we went south, and now I'm here at Memorial Hospital. So I started the MS program there in 2015, and I've been there for 2 years, and it's been great, and I love it. So without further ado, so we're going to talk about MS. So this presentation is about MS symptoms and their management. And so I want to start off by letting you know that I have no disclosures related to this talk. So a little bit of an introduction. What is multiple sclerosis? Multiple sclerosis is an autoimmune disease, an inflammatory one that causes inflammation in the brain and in the spinal cord. And I'm sure many of you have seen MRIs of what MS patients would look like. And this is an example of the MRI of the brain showing multiple lesions around the ventricles and in the white matter. And so this is what a typical brain looks like that has MS. And usually we diagnose MS based on the patient's symptoms and the patient's history and on the MRI. So the first objective is we need to understand what MS is. Before we talk about symptoms, let's just understand MS first. Okay? So I'm going to give you some background about what happens in MS patients. And so here is a blood vessel in the brain, and if we open this up, so we find white cells in there that are called T cells, and there are some that are called B cells, and then you also have red cells. And so then somehow the B cells activate those T cells, and you have also dendritic cells that activate the T cells. And so once those T cells become active, then they kind of become loose and they enter the brain. And then, they're no longer in the blood vessels, and now they're in the brain, and they become active, and so then they cause all different kinds of damages. And then each one of those cells damages the nervous system in its own way, and so you usually lose the myelin, which covers the nerves, and then it also damages the nerves themselves, and you can it'll damage the support cells also. So then the next part of this is understanding what the typical course is for an MS patient. And so if this is kind of the line that MS patients develop in terms of their symptoms and their disability. And usually in the beginning, you have these symptoms that come and go, and we call those relapses. So in the beginning, you're going to have more relapses than later on in the disease course. And we're going to draw a line here to show this is the threshold. So if we put this imaginary line as to when would someone notice a symptom, because you can certainly have activity before someone notices. and then you can have activity after someone notices. So that's what this line represents. And so then this point would make it CIS, or the first clinical symptom. So we call this clinically isolated syndrome. And so whenever the patient has their first attack. And some patients know about this and some patients don't. Now, once you have more than one, then technically it's a relapsing remitting disease. And then after that, you get into a transitional period where there are some relapses and then not so many relapses, and it's just like a decline. And then it becomes a secondary progressive where it's just a decline after. Now, I marked also an area called RIS, and that's radiologically isolated syndrome, because sometimes we pick up MRIs that look like MS, but then the patient has never had any symptoms. So we think that this is because we caught the disease before the symptoms developed, and that's why. So, the inflammatory part of the disease, because we said MS is an inflammatory disease, is usually in the beginning when those relapses are happening. So that's why I made this orange line. And then the degenerative part of the disease is towards the end and is a result of all the inflammation, is what we think. And so that's how it progresses. So this basically means that our time for treatment is within that period that I marked here. Because our medications basically suppress the inflammation, and so the time that we really want to treat patients is in that in that time frame. Okay, so next is, we're talking about treatment, but what does treatment mean? So we have to talk about the different treatment modalities that we have. So, so this is another way to look at someone's disease course. And so if they have a relapse, it comes and it goes, and we treat that relapse usually with steroids, is the most common way. Then you also have a disease-modifying therapy, as most of you have heard about those. Those are the medications that are either injectables, orals, pills, or IV medications. And we have 15 of those right now. And so usually, when someone is treated, for a relapse, you just treat them for a short period. For the disease-modifying therapy, they're usually on something for the length of their disease course. And then you also have symptoms, okay? I separated these out because it's important to understand that this treatment is not for that and not for that. So each one is treated differently. So I get many patients who tell me that, well, I'm on this injection or I'm on this pill and I don't think it's doing anything. Well, yeah, you're not supposed to know that it's doing something, because patients who have hypertension or high blood pressure, they take their medication, they don't feel any different, but it's working on their blood pressure. So it's the same thing that goes for MS treatments. For symptoms, yes, we have our own therapies that treat the symptoms that don't treat the disease. So these are different. And then if you want to see, how a patient's course overall is, well, patients can have many relapses, and so we treat each relapse separately. And we can treat different symptoms at different times, but they are continuously on a disease-modifying therapy for the most part. That doesn't change, or it may change, but they're on something. Okay, so now this will lead me to the reason of the talk, or the main theme of the talk is symptom management of MS. So MS patients can have many symptoms, and this is a very lengthy list of symptoms. That's probably not everything that patients experience. Most commonly is fatigue, but then also numbness, tingling, weakness, vertigo, double vision, vision loss, sexual dysfunction, pain, emotional lability, problems with gait, walking, spasticity, bladder dysfunction, bowel dysfunction, cognitive changes, which is memory and processing, depression or mood lability. And then you also have less common symptoms that could occur. So, and some of these patients are MS-related, some of these symptoms are not MS-related, and sometimes it's easy to tell what's what, and sometimes it's not easy to tell what's what. So, although there are many symptoms, we can only talk about so many. And so I'm going to focus on a few here, and we'll tackle these one by one. So the first one is mood and cognition. And this is very common. And so we see depression in about half of MS patients, almost a half. And there's actually an increased risk of suicide in those patients as well. We can also see bipolar disease, anxiety, pseudobulbar affect, which is a mismatch between what the patient feels inside and what they're actually expressing. And cognitive impairment, which is an impairment in their memory and processing. So, and there are many factors that affect depression, and so, yes, a brain lesion in and of itself, so MS organically can contribute to depression, but also their autoimmune dysregulation, and so the body's ability to adjust itself is also impaired. From a hormonal standpoint, you can also have endocrine dysfunction that would lead to depression. Also having somatic symptoms like pain, tingling, numbness, yes, that's going to make someone, feel depressed if they have these. Cognitive impairment, so that would also affect it. This anxiety or insecurity about their disease, that's also another reason for depression. Psychosocial stressors, and so the patient's support system or the lack of support system or everything else that is surrounding them in their life. And so that would also affect it. And then how we really manage or tackle depression, it's very complex, and so a lot of it has to do, or the best way to do this would be, individualized cognitive therapy. And so having a therapist, someone to talk to and discuss things. But then sometimes we need more than that, and so there are certain medications that would also help. And those are medications, like SNRIs, bupropion, mirtazapine, TCAs, tricyclic antidepressants. So we have multiple categories of medications, and sometimes we could use medications that are kind of a 2-for-1. And so if the patient has other symptoms, like if you have neuropathic pain and anxiety, then there are certain medications that could help. And then if you have you want to improve energy, or you don't want the sexual side effects, or someone wants to quit smoking, so you could use bupropion. For sleep, you could use mirtazapine. If you have also neuropathic pain, sleep issues, and bladder overactivity, then tricyclic antidepressants could also help. So sometimes, we could use different ones to help more than one symptom. Sleep disorders are also very common, and there are many reasons why someone cannot sleep. And when my patients tell me that I'm having problems sleeping, then it's like, okay, here we go. So what time do you go to bed? What time do you actually enter the room to go to bed? When do you think you fall asleep? Is your sleep interrupted? When do you wake up in the morning? And so do you nap during the day? And then you take some more history, what are some of the medications that you take, your drinking, your eating, there's so many things that you have to take into consideration when you're managing sleep. And there are sometimes, it's not just, there's another reason why someone's not able to sleep, not just that the fact that they can't sleep. So they can have spasms, pain, if they have periodic limb movement disorder like restless leg syndrome, if they need to go to the bathroom, if medication side effects could be depression, it could be sleep apnea. And so, we really have to do a good job at trying to sort out where the sleeping problem is from. And so we do a sleep study sometimes. So we'll refer patients to a pulmonologist or a sleep specialist, and they'll undergo a sleep study. We can try to look at their sleep hygiene, and so those are some of the things that I mentioned. So, if you're laying in bed but you have a TV on and everyone now has a tablet, and the light from the tablet actually stimulates the eyes to make you think that it's daytime. So that could be a reason why someone can't sleep. If it's a movement problem in the legs, then we need to treat that. If it's a bladder problem, going to the bathroom, we need to treat that. If it's depression, then we need to tackle the depression. And so we really need to look into that. Another thing about is habit, and so drinking, fluids. If it's a bladder problem at night, but that's because you're drinking 2 8 ounces of water, glasses before you go to bed, then we need to adjust some of that. If it's a stimulant, then we also need to adjust that. So it could be quite complex. And sometimes we figure it out and sometimes we can't. And usually you always have to chase the reason for the sleep problem before you prescribe pills. And so try to chase the problem, treat the problem, and then if all else fails and there really isn't any solution for it, then there are some sleep aids that we could prescribe or use. So fatigue is very common, and there's a reason why I didn't put it as the first symptom to discuss, even though it may be the most common symptom. And that's because fatigue is also multifactorial. And even though 75 to 90% of MS patients have fatigue, most of the time it's because of something else. And so depression, problems sleeping, insomnia, a side effect of a medication, deconditioning, just not moving so much will give you fatigue. Chronic stressors that you have, that'll also give you fatigue, and then multiple comorbidities. So, most patients don't just have MS. You could have other diseases, and so especially vascular ones are common. High blood pressure, cholesterol, diabetes, those can affect the healthiness of your vasculature and hence the brain and affect fatigue. And so usually whenever someone says fatigue, it's the same thing. Okay, well, let's go through your memory, cognition, your mood, depression. Let's look at your sleep. How is your sleep? Medications, let's take a look at those and then try to sort it out and see if you can find the cause of the fatigue. And then if you really cannot find a source, yes, MS patients can have fatigue that is unexplainable. And so in those situations, then maybe we could use some medications that would help fatigue. Keep in mind is that we do not unfortunately have a medication that's approved for fatigue in multiple sclerosis. So these medications are all off-label, but then we try them because we found out that some patients benefit from them. And so one of the easiest ones to try is amantadine, and it's an old antiviral medication, but then it's cheap and the insurance companies don't give us a hassle when we prescribe it, and so we try it sometimes. And then diaminopyridine, or it goes under the brand Ampera, is actually not approved for fatigue, but it can help sometimes with fatigue, especially fatigue that is heat dependent or heat related, which now it's, we're in South Florida and it's summer, so we have a lot more of that. Modafinil also helps with fatigue. Modafinil, though, is a medication that is used for excessive daytime sleepiness and narcolepsy. And so this is an expensive medication that insurance companies don't like us to prescribe. And so usually we have to find a backdoor or a loophole to prescribe it. And maybe we're successful sometimes, we're unsuccessful in many times. So it all depends on the insurance. Our modafinil is a similar medication. And then if all else fails, sometimes we could try stimulants that we would use in ADHD. Sometimes those help. We always have to think beyond the pill. And we have to think of natural ways and healthy ways to manage our symptoms. And so I really think that psychoeducation is important here, and this is one of those where a therapist could help. And so taking control of your fatigue and mindfulness meditation, I strongly believe that they help decrease fatigue. And then exercise programs, I'm a very strong advocate for exercise. And so yoga, finding ways to cool yourself if heat is a cause of fatigue. And hydrotherapy is also another way, a good way to exercise yet control the heat. So next is pain. Pain is also can be multifactorial. There are many reasons for patients to have pain, and it's another one of those, I have pain. Okay, well, let's have you describe the pain so we can try to sort out where the pain is coming from. And so, there is nerve pain or neuropathic pain, which could happen from damaged nerves. A focused neuropathic pain in the face is called trigeminal neuralgia because the trigeminal nerve does the sensation for the side of the face. And so sometimes when that gets irritated, you can have trigeminal neuralgia. There's also glossopharyngeal neuralgia, which is throat pain from the glossopharyngeal nerve. And then there's occipital neuralgia. The occipital nerve is in the back of the head, and sometimes that could give sharp pain in the back of the head. You can have pseudoradicular pain. Well, radicular pain, that basically means when the nerve root comes out of the spinal cord. When it gets pinched, we call that radiculopathy, and it could cause nerve pain. That's similar to when patients say that I have pain that shoots down from the buttock down to the leg. So usually that's radicular pain if it's from something pinching on the nerve root. But then MS patients can have sometimes lesions around that area in the spinal cord, and it makes it similar to a pinching sensation, but it's pseudoradicular pain. There's also musculoskeletal pain, which is just pain in the muscles. And then you can also have visceral pain, which is visceral just means that the organs inside, and so sometimes you can have pain from those. And then headaches, migraines, so that's the type of pain that patients can get. Optic neuritis, so that's inflammation of the optic nerve, and it's MS is the most common cause of optic neuritis. And if you have inflammation in the nerve, then when you look to either side, you can have pain in the eye, and that's from the damaged nerve. And then you can have spasms, and spasms is the mildest form of spasticity, which is tightness of the muscles, and spasms can be painful sometimes. So, once we try to sort out, okay, what kind of a pain someone has, so then, okay, if it's neuropathic pain, then the easiest medication to try is gabapentin. So, and then there's also pregabalin, and then there's imipramine and amitriptyline. So I could tell you that the most common reason why some of these medications don't work is because we did not try it enough. And so either it was too short of a duration, or it wasn't a strong enough dose. And sometimes, we can't get to higher doses because these medications can be sedating, they can make you tired. So that may be a reason why we can't go so up on the dose. But, it's challenging to find that happy medium. And then sometimes when one medication, maybe it works, but then it's too sedating and you have to come down on the dose, so then you could use a combination of medications that could work synergistically together to treat the pain. And then if all else fails, then maybe opioid would be the last resort. So opioid medications cause dependence and are not so great to use for long term. Musculoskeletal pain is another one that we often tackle, and the most common reason is deconditioning. And so, when you're sitting for a long period of time, think about you sitting on an airplane, whether you have MS or not. Yeah, you're going to get cramps and soreness in your muscles from not moving. And so the number one thing that helps is physical therapy. So, a course of physical therapy is very helpful. And then medications, anti-inflammatories like ibuprofen, naproxen, Tylenol or acetaminophen would help. And then if not, then maybe steroids. And then again, opioids, tricyclics can sometimes help. All right, so moving on now to a slightly different symptom, and so bladder dysfunction. So bladder dysfunction is one of those that also can be multifactorial. So think of the bladder as too much or too little. So you could either have an overactive bladder where patients will have symptoms, I gotta go right now, I have an urge, I can't hold it, and then you end up with accidents or leaks or incontinence, or there's frequency, and then that could sometimes be an urgency at night. We call it nocturia. And there's the opposite end of the spectrum, which is urinary retention, which means that patients cannot actually urinate, and they're retaining urine in the bladder. What sometimes ends up happening is there's urinary frequency where the patient often goes to the bathroom, but then very little is coming out, and they're retaining a lot of it. So, and many patients can have a combination of these symptoms, and so we have to try to sort out what kind of a bladder problem it is, and then manage it from that standpoint. And so usually patients undergo urodynamic studies, and so we have an ultrasound machine, we measure the bladder before and after someone empties, and then we see if patients retaining urine or not. And then based on the history also, you could tell what kind of a bladder problem it is. And this is done in conjuncture between the neurologist and the urologist. And so we try to sort out these problems. And then, it's important to do urinalysis and urine culture because a lot of times the source could be a UTI or a urinary tract infection that's causing the problem with urination. So we treat first thing in the treatment of urinary problems is, again, going back thinking natural before the pill popping is what else could we modify from the lifestyle to help. And so fluid titration, and so kind of reviewing how much drinking there is throughout the day. And by drinking I mean just all fluids, not drinking alcohol. So, and then also especially in the evenings or at nighttime, restricting the amount of fluids that someone drinks. And so cutting it off a few hours before bedtime, and then scheduled voiding. Sometimes that could help if you train the bladder that I'm going to void on my schedule, not you telling me when to void, and so sometimes that would help. And there are some stimulants that kind of irritate the bladder, and so like alcohol, caffeine, citrus drinks or fruit. Artificial sweeteners, so those could also affect the bladder. And then one thing that could help is Kegel exercises. This is what a Kegel exercise would look like, and this is something that could easily be looked up on YouTube or on the web. And then there are also Kegel exercises for men. You could look that up too, to strengthen those bladder muscles. So then the next step would be is to try medications for urinary retention or an overactive bladder, and we have multiple that we could sometimes, it's a trial and error in terms of which one would work and which one wouldn't, and sometimes the insurance helps us with that decision. So other ways to treat bladder problems, and so that would be botulinum toxin, which is Botox, and so some Botox injections to the bladder would help decrease some of that overactivity. Sacral stimulation, kind of the same principle as the stimulator devices for the nerves. And then, whether there's the need for intermittent catheterization or chronic catheterization. We try to leave that as a last resort, but sometimes we have to go there. So the next symptom to talk about is physical activity, or I guess physical inactivity would be the symptom. So I put this picture up to kind of, I guess add a little drama to it. So, but before the year 2000, and I'm going to call this the Stone Age of MS, because we used to think that physical activity is bad for MS patients. And I am told that neurologists used to tell patients is don't exercise, don't move, because it's only going to make you worse. So we've learned that this was all wrong. So the American Academy of Neurology, they put together a systematic review a couple of years ago. And they looked at all the rehab data that we have from 1970 to 2013. So they collected 5,400 studies. And they kind of narrowed it down to those that are good and take out the bad ones, and those that are really related or have some meaning. And they came out with that weekly home or outpatient therapy improves balance, disability, and walking and gait. Inpatient exercises for a duration of 3 weeks, actually followed by home therapy or home exercises, improves disability overall. And then a 6-week comprehensive multidisciplinary outpatient rehab will improve also disability and function. So the bottom line is that whether it's inpatient, outpatient, or at home, any kind of therapy is beneficial at decreasing disability and improving mobility and activity. Okay? And you would be surprised how many patients you ask them, when was the last time you had therapy? And if they do this for a split second, we're in trouble. So another indicator of how important physical activity is. This is a very interesting study because it was done on patients with pediatric patients with MS. So these patients were from 5 years old up until 18. Okay? So why is pediatric MS so different? Because they usually are relatively newly diagnosed when you're evaluating them in a research study. And then they also don't have other diseases that adults have. So no back pain, no diabetes, no hypertension, nothing else. And so the pediatrics, so they should have very little symptoms. And they compared 110 patients that have MS versus those that have other demyelinating or other autoimmune diseases, like optic neuritis or transverse myelitis or anything else. And, it wasn't, they didn't have MS for a long time because they're pediatrics. And so, on average, they had 1 to 3 years of the disease. So it's not a long time. And look at this. 45% of these 110, so about 40 patients were active or had physical activity, and 80%, so twice as many patients who did not have MS were more active. So we could tell that MS patients significantly have less physical activity because of their impairments. And then these patients, when they underwent strenuous activity like running and jogging, they had smaller lesions on their MRIs and had less relapses overall. So physical activity is very, 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 very important. So since we're talking about physical activity, let's talk about walking, gait. So many reasons why a patient can have problems walking. And so most of the time it's because of a motor problem, which means that they have weakness or spasticity, tightness in an arm, or they have a problem with balance, and so that's ataxia. Also, if you have a sensory problem, so if you can't feel the ground underneath you, then you're going to have a sensory ataxia, a problem walking, because you need that feedback between your leg telling you where you're stepping and then your leg actually stepping. So a problem with sensation would also give you problems with walking. Upper extremity, the natural way to walk is to swing the arms. So when you have weakness in an arm, even though the weakness is not in the legs, so that's going to throw your entire balance and posture off. And so there's going to be a problem with gait. Vision. We're also very dependent on visual input when we're walking. And so a problem with our vision is going to impact our ability to walk safely. And then cognitive. And so if you can't be self-aware of your walking, and even outside the world of MS, we see this in patients who have dementia. So they usually have what we call an apraxic gait. They have normal strength, they have normal coordination, but their brain just cannot process the whole walking formula. Then fatigue also impacts our ability to walk. And you also can have non-MS reasons for problems walking, and that would be back pain or osteoarthritis. Those would also limit walking. So physical therapy is very important, and it could start with something as simple as stretching. So stretching is very important, which is why we did it 5 minutes before I started talking. So improving range of motion also. And so whenever you have a restricted motion, then you're less likely to move the extremity, and then that's going to get worse. It's a vicious cycle. Strengthening is also very important. And then you can sometimes do task-specific physical therapies, and so that whether that's for stairs or the balance or just walking in a straight line. And then you have to assess for assist device. Some patients will still need an assist device for them to walk safely. And then you can also have mechanisms in therapy, and usually that's inpatient therapy, where you can have this body weight suspension therapy. And so there's a Hoyer that'll hold the weight of the patient so that then they can focus on the walking without their weight affecting it. And I've seen this at our rehab facility. It's pretty neat. And then, when it comes to an assist device, many of you have seen these before. You have to evaluate whether the patient needs a single prong cane, a 4-prong, a walker, a rollator is actually better than a walker, I think is more safe. And then whether there's an ankle foot orthotic that's needed, or a knee orthotic, or a hip orthotic. So, and then you can also have a simulator, which is that very last one, and I'll talk about that. So this is an example of a neurostimulator. This is the electronic version of an AFO, an ankle foot orthotic. If you think about it this way, so the connection from the brain to the leg starts here and then it comes all the way down. MS is a problem that affects the brain and the spinal cord, but the nerve from the spinal cord down to the leg works. So if you can cheat and stimulate it after the spinal cord, then you can achieve that same response. So devices like this will stimulate the nerve to pick up the foot whenever the patient is walking, and so then essentially eliminating that foot drop. If someone has a foot drop from diabetes or something, that nerve is damaged down there, so that's not going to help it. But MS patients, we can bypass that circuit and use it. Now, it's not as pretty sometimes as it sounds. It's also it has its own challenges. And so sometimes the stimulator is not set right over the nerve, and so sometimes it fires, sometimes it doesn't. And if it doesn't fire, then the patient is in trouble because they're going to trip and fall because they're expecting it to pick up. And then sometimes you can get some irritation underneath the simulator. You have to change batteries, charge it, etc. So it's got its own issues. So it works for some, it doesn't work for others, just like everything else. There are some others that are still in their research phase, but some of these are partially implantable, like this one. And then some are even more completely implantable, so you don't see it at all. But then MS patients need their MRIs. So how are you going to do an MRI with this inside the leg? So they're not all that great. We also need to assess the need for wheelchairs. And so you can have, patients may need a regular wheelchair if they are able to use their arms okay. Or they may need a power chair. And, I like this because there's a take-home message here is that we don't quit. And so we try to help patients as much as we can. So because you can't use your arms, so you need a power chair to move a joystick. But if you can't use the joystick, then maybe you could press on a pad. And if you can't press on a pad, then maybe you could push with the head to move the chair. And if you can't push with the head, then maybe you could just blow into a tube. And so there are many ways to make a power chair work, and we're not quitting. So the next to talk about is walking and the walking speed. So a few years ago, a medication came out called 4-aminopyridine, or Ampyra. And they tested it in its clinical trials on it improving the speed of walking in MS patients. So it got approved by the FDA as the walking pill. And it does help speed up walking in some patients. We usually measure patients' walk in clinic, 25 feet. We see how long it takes them to walk those 25 feet. And then after they take Ampyra, we check and see how long it takes them to walk those 25 feet again. And sometimes we see improvement and sometimes we don't. The medication is supposed to improve the conduction of the nerves so that they work better. Of course, we have to watch the kidneys and we have to make sure that the patient's not susceptible to seizures because it can happen. Even though this medication is marketed and FDA approved as the walking pill, some patients have noticed that it improved other functions. And so, it doesn't make sense. Why would a medication only work on the legs? So it should, technically help other functions. Sometimes we notice and sometimes we don't. And so that may be arm function. It may be visual acuity. So some patients may notice that their vision doesn't fluctuate as much. Sometimes their eye alignment. And I've actually remember studying this. And so patients who have double vision because their eyes are not lined up right. And so this medication sometimes could decrease that fluctuation in eye alignment. And so they get double vision less often. And sometimes the memory and thinking, they think that their processing speed is better. And sometimes their speech is also better. And there are some studies that have looked at these and have found some correlation. So the next one to look at is spasticity. Spasticity is essentially velocity-dependent tightness in the muscles. Very mouthy. What does that mean? So it basically means that the tightness happens depending on the speed of the movement. And so if you move the arm or the leg slowly, then you're not so much going to notice the tightness. But if you move quickly, then it locks up. The extremity will lock up the arm or the leg, and it becomes tight. It can be something as mild as a spasm or a jerk that could happen, or something as severe as just a contracture, and then you cannot open up that extremity. And the less mobile or moving the extremity is, then the more likely the spasticity is to happen. And it's fairly common. 60% of patients have some form of spasticity. So we have a scale on how we rate spasticity, and we use it so that if we treat the spasticity, then we see, okay, did it make a difference or not? Sometimes we treat spasticity for not so obvious reasons. So you want to, when you evaluate spasticity, you have to talk to the patient and see what part of it bothers you, or how can we help? Sometimes it can happen and patients are not bothered. You know what, I can ignore it, it's fine. And if it's not doing anything else, then that's fine. You can just leave it the way that it is. And so, but sometimes spasms can be painful, or spasticity can be painful, and you want to relieve the pain. If it's affecting posture, sometimes you have to treat the spasticity to improve the posture. Or if you want to use an orthotic device like the AFO, and you have these toes curled or the foot in a certain position and you can't treat it, then that's another reason. To improve body image, maybe someone doesn't like how their body looks spastic. To improve the function and ease of care, so maybe to dress, put pants on or put a shirt on. It's hard with this extremity being so spastic, so sometimes that's needed. And contractures could lead to ulcers and skin damages, so sometimes you have to treat it from that standpoint. So how do we manage spasticity and how do we improve it? And so the most important thing is stretching, and that's the easiest that can be done. Again, this circulates to the whole physical activity phenomenon. So the more active someone is, the less likely they are to develop spasticity, and something as simple as stretching will help decrease spasticity. There are certain pills, medications, orals that can decrease spasticity. And then sometimes when the spasticity is so focused in one area, then maybe you could treat it directly with an injection, like Botox, botulinum toxin, or phenols, which are alcohol derivatives. Sometimes when the spasticity is global and the patient's walking is not necessarily into consideration, you could use a Baclofen pump to do that. And then you could also try certain surgical techniques as a last resort to treat spasticity. So this is just an example of some medications that we use to treat spasticity. And so Baclofen, tizanidine, benzodiazepines like clonazepam, diazepam, gabapentin, dantrolene, levetiracetam, clonidine, cyproheptadine, all of these can help spasticity in some way. For patients who, Baclofen is the most common medication that we try because I think it's a great medication, but it's not for everyone. And sometimes it works, but it's too sedating or very high doses are needed. And so a Baclofen pump is a good alternative. So, but it's a process. And so you have to test it first before someone commits to a Baclofen pump. So what we do is a trial. So similar to a lumbar puncture, where we'll take a needle, put it in the spine between L4 or 5. Once we get into the space, we'll inject a little bit of Baclofen. And the advantage here is that it's 1/100th of a dose. So it's a very microscopic dose of Baclofen that's put in there. And then we see, did it work or did it not? If it made the limbs too weak, then we know, okay, it was too strong of a dose, we need to cut down more. If it didn't work enough, then maybe we need to try a higher dose. So we go back and forth about this, and then we see, okay, and then the other question is whether the patient liked it or not. So once that's done, then a pump can actually be inserted, and you can have the catheter and the wires, and the pump then can be refilled over the skin, and the actual pump is underneath the skin, so it wouldn't show. So it has some side effects, so just like everything else. And so it can be too strong, and so it'll cause a decrease in tone, hypotonia. It can cause sedation, sleepiness. It can cause dizziness, nausea, vomiting. And the problem is that the pump has to be refilled every 3 months. And if someone forgets to refill that pump, the patient's in danger because you can have a withdrawal effect, which is everything goes the opposite direction. And so you develop high fever, a change in memory and thinking, altered mental status, and then rebound spasticity where someone becomes tired and paralyzed completely. And then you have to give the baclofen back and then they loosen up again, or the effect goes away after a while. And then you can also have some problems associated with the catheter, so that's another problem. So it has its advantages and its disadvantages. It is still reversible, and it's, after the insertion of the pump, it's non-invasive after that because you just refill it from over the skin. And the tolerability is better than the pills. And you can give it steady dosing so patients don't notice that fluctuation in their symptoms. So when I take the pill, my symptoms are better, but give it a few hours later and then I'm worse again, and then I have to take another dose. So this would give the patient a steady dose of the baclofen. And so the complications, infections, catheter issues that we talked about, overdosing or withdrawal. So it has the issue. And then cost, obviously, just like everything else. Whenever the spasticity or the spasms are focal, then sometimes we could do a focal treatment, focusing on that area. And so botulinum toxin or Botox or myoblock could help. We do this with EMG guidance. And so we have our EMG machine. We put the needle in the muscle that we think we want to inject, and we listen to the muscle. We make sure that that's the muscle that we want. And then, or sometimes we'll stimulate the muscle. So we make sure that we're in the right spot. And then we'll inject the botulinum there. And this would give you an effect for 3 months. So it's a great treatment. For patients who are not good candidates or they couldn't tolerate the Botox for some reason, then you can also use phenols, which are alcohols. Same concept goes, is that you inject it into the muscle. It lasts longer, it's cheaper than botulinum. And for those that don't tolerate it, so this is an alternative to use. So we use it less frequently because I think I think the success rate with the botulinum is better. Next is everyone's favorite topic. So I get asked about this frequently, and I consider myself a scientific person, and when I answer questions, I like to answer them scientifically. Okay, so what do we do with patients who say, I want marijuana because I heard that it's great for spasticity and it helps? Well, I say the American Academy of Neurology in 2014 did the work for me. So they took several research studies that were done, actually all the research studies that they could find on oral cannabis or smoked marijuana or nabiximols, which are sprays. And they looked at these studies one by one and they came up with guidelines. So what they found is that although patients reported that it helped them with their spasticity, when we measured it in clinic, we did not find a difference. And so, given all the numerous side effects that patients can get from chronic marijuana use, we are advising against marijuana and its different forms for spasticity. So, in conclusion, because I talked about a lot of things, so I'm going to try to summarize this for you. The disease course in MS is variable, and I kind of went over on how it starts and how it ends, and we always have to figure out where the patient is in that disease course so we understand how to treat that patient. The treatment in MS is multifaceted. There's not one medication or treatment that's going to treat everything. So you have to understand, go through your medication list and understand what each one is for. So there's the one that treats the MS, there's a relapse treatment, there's a symptomatic treatment, and not one replaces the other. MS patients can have a variety of symptoms, and we went over a few of those. And so sometimes they're pretty obvious and sometimes they're not, and we have to go through some sorting out to see which one's which and see if we could help it in that way. Fatigue being the most common and the most challenging to treat. And exercise is very, very, very important. Please exercise and stretch. Thank you so much.